Welcome back to Voices for Vitality, where we have real conversations with the incredible professionals helping older adults live fully, age confidently, and navigate the many seasons of life. Today's conversation is a really important one, and honestly, one that families don't talk about until they absolutely have to. We're talking about hospice. Joining me today is Amber Powell, a hospice nurse with Faith Hospice here in Western Michigan. Faith Hospice provides compassionate medical, emotional, and spiritual care to patients and their families during serious illness and at the end of life. Amber, thank you so much for being here today and for the work that you do every day.
Thank you for having me. I'm excited about being here with you.
Great. Well, let's get started with your story. So, tell us a little bit about what led you to become a nurse and then eventually a hospice nurse.
Sure. So, growing up, I was very passionate about teaching and helping others. So, honestly, it was between being a teacher and a nurse. And then I finally decided that as a nurse, I can also teach. And that's a huge part of what I do today. I started out in the hospital at Butterworth working orthopedics and progressive care, night shift, holidays, weekends. I quickly decided that was not for me. I've done everything from endoscopy to ICU, and then eventually landed in hospice. And I think one of the drivers of that for me was being able to be by my grandpa in 2014 when he suffered a massive heart attack. And we had to make the decision as a family, and him, he could still make his own decisions, but to just withdraw, aggressive interventions. And I was with him when he took his last breath. And it just it impacted me in a way I didn't realize. And I kind of ignored that nudge from God for about 5 years. And then I saw a posting for a hospice position and I applied. I was scared because I wear my heart on my sleeve. I feel for everybody. Doesn't take much for me to cry. And so my parents were like, "What are you doing? There's no way you can do that." And so within probably an hour of applying, I had a phone call to set up an interview for the next morning. And then within 20 minutes of my interview, I had the job. And so that was a different hospice company. I stepped away for a little bit during the COVID-19 pandemic. And then now I'm back at Faith Hospice, where I've been for 2 years.
Wow, that is totally a God thing, right?
hmm
That is wild. Did you find that it was a difficult transition going from, that hospital setting where, you kind of you're seeing patients for a shorter period of time, and so it's a little bit easier to go home and kind of pull yourself out of the day, whereas like in hospice, I don't know, you're with people for a little bit longer, you're getting to know more of their family, and you're kind of becoming one of the family members. Was that a tough transition for you?
Yeah, it's definitely different. And not only that, but I think the mindset going into it, in nursing school, it's all about saving people and what do we do to treat this? And hospice is really taking a step back and saying, okay, we've done everything we can. Let's focus on quality and comfort. And so, when you have a patient and something's going on and family is anxious about it, and you might not ever know the answer, but we're going to treat the symptom. And so it's shifting your mind in that way. That was a huge transition for sure.
Yeah. So talk us through a typical day. What does a typical day look like for a hospice nurse?
Yeah, so that's the thing about it. There are no typical days. You start your day with your plan, and then you kind of just chuckle as it all goes up in smoke sometimes. So I manage a caseload of about 20 patients, and so I'm responsible for them. I would say 24/7, but that's not true. I have people that look after them after hours, but I manage all of their care. So I set my own schedule. Each day I see a different set of patients. I try to keep them on the same day every week. So I know going into it kind of my plan for the day. I do check my email when I wake up and see what happened overnight. Someone might have a symptom needing managed that I wasn't planning on seeing today, but now I'm going to go see them. And so it's just going place to place, visiting with them, making sure they're comfortable and have what they need, and then kind of moving on to the next one. So,
And what surprises you most about hospice nursing, aside from just like the surprises that you get every single day when you wake up in your email?
yeah, I mean, aside from that, I think just the fulfillment I guess I don't know if that's surprising or not, but it's so fulfilling and rewarding to do what we do. You know, families and their patients or their loved ones are so thankful. And I just love being the person that can show up there and maybe not have all the answers, but have most of them. And if I don't have all of them, I can find out, and just being that source of calm in a chaotic environment.
Yeah, I think that to me is actually really surprising. I just feel like, you're constantly in what can be oftentimes a very stressful and emotional environment, and that can be hard. So when you say fulfillment, that does actually surprise me for
Yeah.
sure. So I think a lot of people really don't understand what hospice actually is. So when people hear the word hospice, what do you think that they are usually thinking? And then piggybacking off of that, what do you wish they actually knew about it?
Yeah, that's a great question. And I'm glad that you asked, because a lot of people are under the idea that, hospice means I'm dying. I've got just like 2 weeks left to live, and they're going to come in and give me morphine and I'm just going to die. And that's not at all what it is. Yes, we do use morphine for symptom management, but it's used in such small amounts and we go very slow and we titrate it. Our goal is not to hasten or postpone somebody's death. It's really just to come in and support. So, really, we try to get people under hospice care really the sooner the better, because it's such a great benefit. And some people do wait too long and then they don't get all of the benefits of having hospice involved for a longer period of time. So, I really just wish people knew that it doesn't mean that you're going to die, in a couple of weeks. It means that you have a life limiting illness that there's either no more treatment for, or you're deciding that you don't want any more aggressive treatment, and then we come in to help support and keep you comfortable.
Mm, I love that. We don't see a ton of people at the end of life, just because the purpose of therapy is restorative physical
Mhm.
function. But we do see a few, and I do feel like we see what you're saying. We see that people are, waiting too long, right? They
Yeah.
they consider hospice nurses like, I've heard the angel of death, which
Yes.
is like so morbid. So if you had to tell somebody, like what the right time to call in hospice would be, what would you recommend?
Yeah, I think it definitely varies depending on what the diagnosis is. But let's just say, for example, a lot of our elderly population have chronic heart failure or COPD or dementia. And really, those are hard to prognosticate, right? Because in heart failure and chronic respiratory diseases, it's up and down with symptoms. And so any one of those downs, an exacerbation of symptoms, sends them to the hospital. That could be their death. But a lot of times they rebound. So it's hard to prognosticate that. But I would say when you've gone to the hospital several times in the last 6 months, you've got frequent infections. Symptoms are getting worse. So with heart failure, more difficulty breathing, maybe swelling that's not going away with the use of diuretics anymore, things like that. And like when you make that decision that I don't want to go back to the hospital, I want to be comfortable, I want to add quality over quantity of my time left. I think that's really when we say, yeah, let's start that referral.
And what are the signs, or what, I guess, are the qualifications for, a referral to be accepted?
Yeah. So anybody, first of all, anybody can make a referral. So if you have a loved one at home and you're looking for more help and they don't want to go to the hospital, you can always call us. If you call our main number, we have nurses that answer. We have an intake team that takes all of the information. What happens then is we send out a team to provide an informational visit. So this is like no strings attached. We're just giving you information on what the services are and let you make that decision for yourself. If you decide you want to proceed, then we send out an admission nurse. That nurse does a full assessment, looks at medical history, looks at any weight loss, again, infections, hospitalizations, falls, and then they review that with our hospice doctor, who either says yes or no. And so to qualify, you do have to have two physicians that agree that if your disease progresses naturally without aggressive intervention, that there's reason to believe you have 6 months or less to live.
Okay, so just to kind of clarify,
Mhm.
the individual that's calling for this assessment doesn't have to have those two doctor referrals before calling. It's the
Correct.
assessment that then triggers. Okay.
Yep.
And the physicians would be one, your hospice physician, and then
Yep.
who's that second one typically?
It kind of depends. So if somebody's primary care physician sent the referral, we would confirm with our hospice doctor first, then we would call that physician, whoever made the referral, we would call them to verify that they agree with this diagnosis and that there's a 6 month prognosis. And then paperwork gets sent to them too to like officially get the signature. So if it was a family referral, then we would contact their primary care physician.
Okay. And
Yeah.
then you had mentioned heart disease and dementia as being some of the common
Mhm.
conditions that you really see in individuals that are signing on for hospice. Anything else that you guys see on a pretty regular basis?
A lot of cancer, unfortunately. And I think the heart disease, dementia, respiratory illnesses are very common among our elderly population, but then we do get a fair amount of middle-aged folks that have a cancer diagnosis as well.
Yeah. Yeah.
Hmm.
So let's talk a little bit about what hospice actually looks like for the families. What services, we talked a lot about like symptom management,
Hmm.
but what services does hospice provide that people might not realize?
Yeah. So not only do you get a nurse, but we have spiritual caregivers. So Faith Hospice is a faith-based organization, but that doesn't mean you have to have a faith background. We believe that everybody has a spiritual need. And so that's where our spiritual caregivers come in. We also have social workers. They can help facilitate power of attorney, funeral arrangements, all the paperwork that kind of becomes overwhelming to families. We offer home health aides to come in and help with, showering or bed bath or helping with meals, whatever the case may be. The nurse, obviously. And then we have some complementary therapies as well. So we have music therapy. I've seen that work really well with people that are agitated. Our music therapist will come in and play to like the beat of their breathing. If they're breathing very heavily, they'll start there with the tune and then they'll slowly lower their tune, make it just slower. And the patient's breathing follows it. It's amazing. We also have pet visitors. So we have there, it's a volunteer basis. So people will bring their pets and visit with families that are open to that. We just implemented an aromatherapy program. So we have little tabs that we can stick to people's chest so only they can smell it. And it helps, there's different scents to help with different symptoms like pain and anxiety and nausea. We also offer massage therapy, which is really great for not only pain management, but edema management. So people that have that chronic swelling in their legs or wherever the case may be, our massage therapist can come in and kind of work that swelling out. Um, I'm trying to think. Oh, we have respite volunteers. So if a family member is needing to go grocery shopping, I have one of those right now, and they have a respite volunteer that comes every Monday, sits with their loved one for a couple of hours while they're getting groceries, and just so they have that peace of mind that somebody's there with them.
Oh, that's great. Sounds like an awesome team. Very
Yeah.
comprehensive.
Hmm.
So the very first question we ever get asked anytime we make any kind of recommendation is who pays?
Yeah.
So how is hospice covered?
Yeah. So it's actually covered under the Medicare hospice benefit. So when somebody signs on to hospice, assuming they have Medicare, primarily that's the primary cover of most of our patients because they are of age. So they elect the hospice benefit of their Medicare, and this is something they've paid into for years during their time working. So what happens is Medicare pays us directly, and so for each patient, we get like a lump of money each day. And so we use those funds to cover supplies and all the visits and everything else. So there's really no out-of-pocket cost for the family. Occasionally there are medications that, like cholesterol meds that are really not beneficial anymore. But we don't ever come in and tell people that to stop taking them. We say, you probably don't need it anymore, and then let them make the decision with the understanding that if they continue it, it's an out-of-pocket cost. But other than that, everything is covered that is
That's
needed.
interesting. I didn't know that about the medications.
Yeah.
So is that just like any type of medication that they have that's more of a like restorative type medication?
Yeah. So
Okay.
one thing I learned from one of our doctors, which is astounding to me, is so something like Prevestatin. It's a cholesterol med. And the benefits of that medication stay in your system for up to 6 years after you stop taking it. So,
Really?
yes. And so when we're thinking of people that have a 6 month life expectancy and, they're having trouble eating and swallowing, it's like, that's the first one to go.
Right,
Like, get it
bye.
out. We
See you
don't need it.
later.
So,
We're done.
or things like Eliquis. We have a lot of people that take that in heart failure and cancer. It's a blood thinner, very powerful blood thinner. Um, the problem is it can cause different risks of bleeding too. So if we're talking somebody who's getting weaker and they fall and hit their head, they're at a huge risk of a brain bleed. So with Eliquis, you have, I think it's like a 1% chance of developing a clot. With a baby aspirin, you have a 3% chance of developing a clot and not the risk. So we often make that swap and then hospice will cover the aspirin.
Interesting. Right. Like I'm
Yeah.
taking that swap any day.
Yeah.
Right. Like I'm taking my
Absolutely.
3% chance
Yes.
over like a brain bleed because that's just
Yes.
not, that's not a glamorous way to go at all.
Mm-mm.
At all. So how often do you as a nurse visit patients? And then how often can they get the extras like the home health aide and the massage therapists and the music therapists, pet
Yeah.
therapy, like, you know what I mean?
Yeah, great question. Nurses have to go at least once a week. But so I usually start with once a week, and then once I get to know my patients and their needs, I will increase as things start to deteriorate. When somebody reaches the point where they're actively dying, I do go every day. Um, so it's very individualized on what the patient needs and preferences, really. Our aides, we can send out once a week, or we have people that are 7 days a week. I would say 7 days a week is kind of rare because hospice isn't meant to be like the sole provider. It's a supportive service. Family is expected to kind of play that caregiving role. Our spiritual caregivers and social workers usually every other week, but could certainly visit weekly if needed. And then music therapy, I've seen every other week or so. Massage therapy, I have somebody receiving it twice a week. So
Hmm.
it's very individualized on the needs and the availability of our therapists.
Yeah, that's great. So a little bit more about your spiritual
Mhm.
um, providers. Are they working like just with the patient themselves, or do they work with the family members as well? Because I know that it's not necessarily hard only for the person that is
Right.
making that transition, but it's hard for everybody else involved, all
Yeah.
family.
I would say we treat like the patient and family unit as one. Spiritual caregivers, social workers, nurses. I'm constantly providing education to the patient and their family. Spiritual caregivers are doing the same, supporting them, trying to assess where they're at in their level of acceptance and their grief journey, and really supporting everybody, which I think is really cool because the family is very much as important to us as the patient is.
Yeah, absolutely. So tell me a little bit about what a visit looks like for you. So you get to the patient's home and then what? Or
Yeah.
wherever the patient is.
Yeah. So it kind of depends on what I'm going for. If it's a routine visit, I'm coming in, saying hi, checking vitals, listening to their heart, lungs, belly, um, asking the questions like, when was your last bowel movement? Because that is very important, believe it or not. Asking about pain, appetite, their level of energy, how are they sleeping at night, kind of going through. A lot of people are great and they'll make a list of questions to ask, which is
Mhm.
fantastic. And so I try to address everything right there. I try to be proactive on, what might we anticipate over the next week. If there's something I need to order in the meantime, whether it be medication or supplies, I do that in the visit. I can collaborate with our doctor, which is amazing. Each of our teams, we have a north, south, east, and west team. I'm on the east team. So we have our own doctor that we can direct everything to. And so I just shoot her a quick message in a visit and I say, all of our messages are HIPAA compliant. So I can tell her who I'm with, what's going on, and get her recommendation in real time, which is amazing. Um, a lot of times I set up medications for people. If they're at home, I'll set up their pill box for them, make sure they have all their supplies and everything else, and then we'll get their next visit scheduled on the calendar, and that's pretty much it.
That's awesome. I think
Mhm.
it's so important and so nice to have that skilled nursing piece along the journey too, to help
Mhm.
answer all those questions. Because I think that sometimes physicians can seem unapproachable to individuals. I mean, they're not, right? But to have a skilled professional in the home helping them on the
Mhm.
journey, I think is so important.
And I think
Speaking
something
of,
else, I was
what's
going to
that?
say
Go ahead.
something else really cool just on that note. Our physicians will actually come out and visit with us when we get a new home patient. So,
Really?
yep, we'll coordinate a visit together so that the patient and their family can meet our doctor. So it's not just like a name behind the scenes.
That's
They can put a face
incredible.
with the name. Yeah, it's really cool.
So does the individual then discontinue services with all other healthcare providers, all their other doctors, and then your hospice physician becomes their sole
Yeah.
provider?
Yep.
Okay. Okay. That's great. So we've
Yeah.
talked a lot about hospice happening at home. I think
hmm
like our default is home, but are there other places where people can receive hospice care?
Yeah, absolutely. I mean, wherever it is they call home, we can go to skilled nursing facilities, assisted living, independent living, apartments. Um, we have actually provided care to somebody in a shed type of establishment that didn't even have an address. So,
Okay.
really, wherever they call home, we also have our 20-bed inpatient unit at Trillium Woods where people can receive hospice services as well.
That's in Byron Center, right?
Yes.
Right off
Yep.
of
It's
84th.
nestled.
Okay.
Yeah, it's a really convenient location and it's kind of nestled back in the woods. You can't see it off any main roads. It's a beautiful place.
Yeah. And then, so those individuals that are maybe in an assisted living or a nursing home situation, do they have do they have the ability to choose whatever hospice provider they want, or are they typically, encouraged to choose certain providers?
Do you mean like hospice companies, like Faith Hospice versus
Hmm.
Corewell? Yeah,
Yes,
anybody,
yes.
yeah, anybody has the ability to choose who they want. And so a lot of our hospitals locally have their own hospice service that they will recommend, but they do provide a list of available providers in the area, and then they have the ability to choose which one they want to go with.
That's great because from what you said earlier, it sounds like different hospices have different, um, I guess, extras
Yeah.
involved in them. So,
Yeah, so Medicare requires a physician, a nurse, an aide, spiritual care, and social work, and volunteers. And
mm,
then that's, we have to have that to be a hospice. And then all of the extras are things that, we use money from donations and things like that to support those extra services.
I love that. So then when somebody is in hospice, what role do family or caregivers play in their care?
Yeah, that's a great question too. It depends on where they live. So if they're at home, it falls a lot on family and caregivers. A lot of folks choose to hire private duty caregivers so to
Mm.
take some of that caregiving burden off. However, it can be hard to come by, there it's kind of expensive sometimes depending on the financial situation and trying to find somebody to fill those hours. A lot of times people want nighttime and it's just hard to come by that. But if they're in a facility, assisted living or whatnot, then family really gets relieved of that burden of caregiving and they can just focus on being family and being present with their loved one.
Is it possible if they're at home to transition to assisted living? You know, because you
Mhm.
said your place only has 20 beds.
Yeah.
So say you guys are full, is it pretty easy to go from, say, the hospital to then an assisted living so that family has that extra support?
Yeah. Yep. So, I don't know. Sometimes it can take a little bit of time. I'll say that,
Okay.
depending on availability and, if it's an assisted living that we are under contract with. If not, then we have to make sure we have a contract in place so that we are allowed to come in there and care for that person. But a lot of the facilities in Grand Rapids, we are under contract with. So I cover out to Hastings, which is way south of Grand Rapids. And there's a facility out there that has their own preferred hospice, but we do have a patient there. So we've had to write up a contract with them to allow us to care for that person. But otherwise, yeah, it's, we can help facilitate a transfer to assisted living or any higher level of care, and then still follow that person to wherever it is they're going.
That's great because I think there there is a little bit of, I mean, people feel a certain way, I think, about death and then death happening in the
Yeah,
home. And it's just nice to know that if that is the way that you feel, there are other options
right.
than one being in the hospital, because the hospital can just be like cold and
Yeah.
icky, right? So,
Mm-hmm.
an assisted living gives people the opportunity to like bring in their comfort items from home, but like not be in the home in the event that
Exactly.
a spouse is going to be there. I recently had a friend go through the hospice process, and one of the biggest fears, her dad was the one on hospice. The biggest fear was like, is mom going to go back and sleep in their bed
Mm,
again if this happens here? And I think
right.
that that's a real concern that a lot of people have.
Yeah, absolutely.
For sure. So this signing on with hospice is a huge decision made by
Mm-hmm.
individuals and oftentimes a very emotional decision. What are some of the biggest fears that you find family members have when they start hospice?
Again, it kind of goes back to the fear of, okay, this is it, they're going to die. Like it's impending, or that we're going to come in and just start giving medications to assist the process. And that's not true. I think there's also a fear of, okay, I've signed on, now there's no going back, which is also not true. If somebody does sign on and they decide after a couple of weeks, like, I don't want to do this, or maybe they have cancer and some new drug has come out and they want to try it, they can always sign off. It's a quick signature. They sign off our services. Even if they decide that very next day that they want to sign back on, they can, as long as they meet requirements. So I think just knowing that kind of helps relieve some of that anxiety. Like, you're not trapped. We're not going to
Right.
hold you hostage. It's okay. There's always the option to sign off. And sometimes we have people graduate from hospice, which I think surprises people. We've got a fair amount of folks that have dementia that end up in the hospital for something like a UTI that's gone septic and they're really, really sick. They decide to sign on to hospice. They get better after that infection and they just plateau for months and months. And we're like, okay, probably not appropriate anymore. Let's sign off. And then we educate family or caregivers on what to look for, to call us back in. And I've done that a fair amount of times. So,
Yeah, that is so great. We have had a couple patients actually that, I mean, insurance does not pay for physical therapy when somebody's on hospice
right.
unless it is family education. And those are like really infrequent cases, right? If we're like
Hmm.
training family members on how to use a Hoyer lift or how to use good body mechanics to roll somebody on and off a bedpan or transfer techniques or whatever, but really rare cases. So we've had some instances where families have wanted to pay privately because of that. They're thinking, we're making this decision because this is what mom wanted, but like, I just don't see death in the near future. But
Yeah.
I also don't want them, mom or dad, to like lay in bed and get weaker and weaker and weaker so
Right.
that if they do bounce back, then they're essentially bedbound because they're so weak because of
Right.
this. So we have seen in those situations, some of our clients have graduated, and it's a really incredible transition to see somebody bounce back from that degree of illness.
Hmm. Yeah.
Um,
Super true.
so do you think that there is such thing as a good death when it comes to hospice care?
I do. And I've seen so many of them. And I feel like it's my job to make sure that that happens. And I think what quantifies a good death is really the person just appears to be sleeping, right? They're not having any physical signs of discomfort or agitation, and they're just calm, and then they stop breathing. That's ideal.
Love that.
Yeah.
Is agitation really common in
hmm
end of life? Okay.
Yeah. So a lot of times, there's something called terminal restlessness. And so when things are starting to change in the body, stuff slowing down and shutting down, chemicals are changing, it can cause this severe restlessness. And it often presents as somebody like they're bedbound. They can't get up, but they're like, I've got to get up. I've got to go to the bathroom. It seems to always be the bathroom, and you can't
Yes.
talk them out of it. So it's really just we have to use medications to help calm that down, get the person comfortable. Once they get over that hump, it's usually smooth sailing after that. But yeah, that terminal restlessness, it can be pretty severe if we don't treat it.
So, or do you guys find that you see a lot of cognitive changes towards the end of life? Because that seems like there's a cognitive piece to
Yeah,
that too, right? Knowing that you're bedbound and knowing that physically there's no way you can get to the edge of the bed and walk to the bathroom.
yeah.
Um, is there, so you see a cognitive decline towards the end
Yep,
of life?
for sure. A lot of times, like as things start to progress, people will become more withdrawn, not visiting with family, more confusion because they're sleeping most of the time. So their concept
Mhm.
of day and night gets thrown. And yeah, usually they're not eating as much either. So if you're not eating, think about like when you're super hungry, your brain does not function the way that
Yeah,
it normally does. You get that brain fog. And so they're kind of in that constant state of brain fog at that point.
yeah. So, segueing to something a little bit more meaningful, what are some of the most meaningful moments that you have witnessed at end of life?
Yeah, I was thinking about this before the call because I was reading through the questions, and I did have one where this was super hard for me, and now looking back, I see why God did it. But I had a 36-year-old, and his wife was there with him, and I had come to visit. And as soon as I got there, I like held his hand and was talking to him. I'm like, it's okay, you know. And he took his last breath, and his wife was like, I think he waited for you to make sure that we were going to be okay. And that hit me so hard. I had to excuse myself and like go sit in my car and sob because I get goosebumps even talking about it. But, you know, things like that. And the hospice I worked for before this one, we did something called Last Wish. And I had another patient that he just wanted to go fishing out on the lake. So I contacted like a pontoon rental company out on Gun Lake here in Wayland. And we rented a pontoon. We brought his oxygen with him. It was myself, I believe, a social worker. I can't really remember who was with us, but whole group of us. And they took us around Gun Lake fishing, and he caught this huge bass, got to take it
Oh,
home, and it was awesome. Like just a beautiful day out on the water. And then he actually passed away the next week. So
that's
it was
incredible.
just, yeah. So definitely have some fill your cup moments.
For sure. Absolutely. So what do you find that caregivers struggle with the most in this transition?
I feel like, particularly when they bring somebody home, sometimes they don't realize like the extent of the caregiving responsibilities. And sometimes they expect hospice to be there more, you know, that 24/7 oversight. And so that's kind of hard to navigate because, of course, we want to be sensitive to that. We want to be helpful. So we will increase our visits, but we can't be there 24/7. So I think that's a struggle. And just, I see a lot of my home patients, their families struggle with being the sole caregiver versus just being that son or daughter that's able to come in and spend time with their mom or dad, you know. I would say that's probably the biggest thing.
Yeah, and I think that at least I've seen a fair amount of caregivers really struggle with that piece of it as well because they think that they should be the one that is coordinating it and the one that is caring for them. And they feel like they're, maybe giving up
Mm,
or like like stepping away if they hire outside
Right.
help to kind of
Yeah.
help ease that transition. But you're absolutely right. It's a much better final weeks, months or whatever, when you can just sit there and visit with your loved one
Mm-hmm.
and have good times and good conversations, as opposed to the stress of, like cleaning someone up after they go to the bathroom, or trying to get them readjusted in bed, or
Mm-hmm.
always being the one to be like, you gotta eat, right?
Right.
Like, it's just a much smoother and much more peaceful final week or month or whatever, when
Right.
you're the one, when you're like facilitating care as opposed to
Mm-hmm.
doing the care. So what happens after someone passes? Does your support just stop? Or I guess, like, take me through, or take our listeners through, like, an individual passes, then what?
Mm-hmm. Yeah, that's a great question too, because I think one of the biggest fears after somebody passes is you've developed these relationships with your care team, and then it's like, oh, they're just gone, which in some respect is true. That exact care team does not follow, but we have a really extensive bereavement program. And so once somebody passes, every week we have a team meeting where we have to talk about our patients. And so we go through the list of those that have passed in the previous week, and we talk about bereavement needs. So, regular bereavement is a phone call in like 2 weeks. Sometimes we have individuals that are struggling a little bit more, so we ask for an early bereavement call. But we have somebody that follows up on the phone, and they do this regularly. We don't want to hound the people that are receiving these phone calls, so they usually ask, how how soon can we follow up with you? And we kind of follow them for 13 months, actually, after somebody
Oh,
passes.
wow. That's incredible.
Um, and if they're needing additional support aside from, the phone calls, or sometimes we'll bring them in for individual counseling. We also offer support groups of various, like spouses of folks that have passed, or like a son and daughter group, or, things like that, very specific to that individual. But yeah, up to 13 months. And then if they're still needing support after that, we do a really good job at hooking them up with community resources moving forward.
I think that's great, because I think that after a loved one passes, the caregivers, like, the last thing on their mind is like, how am I going to take care of myself? And like, what are
Mm-hmm.
my needs through this? They're always thinking about everybody else that's involved. And then there are so many logistical things that happen after someone passes, that I think that a lot of people don't pay attention to their own personal grieving. And so I think that that's great that you guys reach out and kind of nudge them in the right direction of personal grieving.
Yeah.
But speaking of more of the logistical side of things, so when someone passes, is there a difference in what happens when hospice is involved versus when hospice is not involved? Like, let's say somebody passes at home
Mm-hmm.
and hospice is involved. Is the process different than if hospice is not involved? If that makes
Yeah, and it,
sense.
it does make sense. And it depends too on whether the person has a do not resuscitate order or not. So if somebody passes without hospice, families calling 911, if they don't have a do not resuscitate order, then they're taking them into the hospital, trying to do all they can to revive this person. And then if they do end up passing in, the ED or whatever, then they're pronounced there by the hospital staff. On hospice, they just call us. And anytime, day or night, we have nurses on 24/7. So we'll send a nurse out. The nurse will pronounce the person, and then facilitate the phone call to the funeral home, help destroy any medications that are left so the family doesn't have to worry about that, clean the body up, and get them ready for the funeral home. So it's just, we try to take that burden off the family as much as possible.
Sounds like it's far more peaceful and quiet too, right? Like,
Hmm.
when you call 911,
Yeah.
sometimes like there are bells, there are whistles, there are lights, and
Hmm.
like it's a
Yep.
whole to do at your house.
Yeah.
Whereas like just simply calling you guys and having you come in and just take care of everything just feels more peaceful,
Yeah.
you know,
For sure.
So, all right, before we wrap up, Amber, what do you wish that every family knew before they needed hospice?
I would say I just wish they knew that we are here to support you. Um, it can sound scary, but I promise that we're not. Really here to help support and guide your loved one and make sure that they, again, have quality over focusing on quantity. They might still have more quantity because of the quality, right? So just focusing on managing symptoms and keeping them at home with the ones that they love.
Well, Amber, thank you so much for this conversation and for the work that you do. Hospice nurses truly walk families through the most meaningful and vulnerable seasons of their life. And if you're listening today and this conversation made you realize that you may need support, earlier is much better than later. Having information ahead of time can bring so much peace and clarity. And if you know someone who might need the information, please share this episode. Thank you so much for joining us on another episode of Voices of Vitality, where we celebrate the people helping others live their best life at every stage of life.